Welcome to Nitte, a place where learning goes way beyond the classroom. For some, it's home. For some, it's a step towards transformation. For some, it's the beginning of a wonderful journey with like-minded people.
Thanks to the teaching and mentoring activities and dynamic incubation center, I am now industry ready.
Engineering at Nitte includes aeronautical, civil, computer science, electrical and electronics, electronics and communication, information science, mechanical, biotechnology, MTech, MCA and PhD. Nitte also collaborates with reputed universities around the world to give students an international academic exposure.
At Nitte, the focus on research has not only helped me understand my subjects, but reach for the stars.
Nitte offers a unique co-op program and exposure to architects, artisans and urban designers.
I aspire to be the heart of progress.
Chema is listed in the World Directory of Medical Schools.
I learned the art of helping people smile.
A.B. Shetty Dental College is listed as one of the top dental colleges in the country. Justice K.S. Hegde Charitable Hospital, part of the Nitte Group, has 1,000 beds, advanced labs and diagnostic centers, which attract a good number of patients from across South India. Along with teaching and clinical practices, we offer programs in pharmacy, nursing, physiotherapy, speech and hearing, biomedical sciences, and paramedical programs like respiratory therapy technology, operation theatre technology, medical imaging technology, and medical laboratory technology.
I've always been curious about the chemistry of cures. I help in healing. From toddlers to seniors, I care for them all.
I believe I can help improve the quality of other people's lives.
We are blessed with the ability to speak and hear from birth. Not everyone is as lucky. I want to do my bit to help the less fortunate. I am proud to be able to assist a surgeon in the operation theatre.
From simple X-rays to sophisticated MRI and PET scans,
my course trains me to assist radiologists and physicians. The training I have received in testing blood, tissues and body fluids assures me a job at any clinical laboratory. I help people enjoy every breath.
I believe in the power of research to change the world.
NUINS is a one-of-its-kind teaching and research center that addresses society's health needs through painstaking research in biomedical sciences, food safety, microbiology, and biotechnology.
What I learn here and at my internship in the University of Minnesota, USA, I will carry with me and teach my community to live healthy and stay happy. We believe in being our own bosses.
The Bloomberg Lab helps students stay up to date with the latest trends in global markets. Students also have access to Bloomberg Analytics and can, in the course of their learning, develop their own analytics.
I cook my own recipe for success.
Sarosh Institute of Hotel Administration molds each student to become perfect hospitality professionals. A healthy blend of polish and panache.
I speak for the voiceless. This is what I'm taught, and this is what I'll practice.
I design my dreams and my goals.
I measure success by the trends I inspire.
Bachelors in Fashion Technology at Nitte offer students state-of-the-art labs and the space to get their creative juices flowing. With the best of infrastructure, an active placement cell, and a lively atmosphere, education at Nitte helps students grow, breathe, and bloom. Graduate into a better future. Graduate with Nitte. Welcome to Nitte, a place where learning goes way beyond the classroom.
Okay, ma'am.
A very good afternoon to all gathered here. I, Mrs. Timmy Thomas, faculty in the Department of Obstetrics and Gynecological Nursing at Nitte Usha. At A very good afternoon to all gathered here. I, Mrs. Timmy Thomas, faculty in the Department of Obstetrics and Gynecological Nursing at Nitte Usha Institute of Nursing Sciences, roll down a red carpet welcome to all who have logged into the session on recent advancement in midwifery practice in the midst of pandemic. It's my pleasure to welcome you all this afternoon. Let's light the lamp of knowledge, experience, and power virtually through a video clip and officially inaugurate the event. Light the lamp of positivity and walk the miles with courage. It's my pleasure to request Professor Shiny Paul, Head of the Department of Obstetrics and Gynecological Nursing, to formally welcome the gathering.
Thank you, Timmy. Greetings to one and all, distinguished delegates, participants, and partakers. It gives me immense warmth and great pleasure to welcome you all to the international webinar on recent advancement in midwifery practice. Midwifery is an ancient profession still actively practiced throughout the world. Midwives play an instrumental role to introduce women to the health system and ensure that women and their babies receive a continuum of skilled care during pregnancy. At the outset, I feel glad to welcome our principal, Professor Dr. Fatima De Silva, an ardent reformer and a proactive leader who always strives to motivate and support the team members towards their professional accomplishment. On behalf of Obstetrics and Gynecological Nursing Department, I heartily welcome you, Madam. It is an honor and privilege for me to welcome our eminent speaker and a passionate researcher in midwifery, Dr. Sunita Panda, currently working as a postdoctoral research fellow at Trinity College, Dublin. Dr. Sunita Panda completed her bachelor's degree in 1999 and master's degree in 2004 from Manipal College of Nursing and pursued her PhD in 2019 from the University of Dublin Trinity College. She has worked as a midwife in tertiary maternity hospitals in the Republic of Ireland for over 11 years from 2005 to 2000. Dr. Sunita's main focus of research, reducing inappropriate cesarean sections, promoting physiological labor and birth, and optimizing women's experience of childbirth. I proudly welcome our guest who will be speaking later with her expertise. I would extend a special welcome to all the participants who were inspired to partake in this webinar. I feel extremely happy to welcome Dr. Sabita Naik and our entire departmental team, and a great appreciation for the meticulous effort and making this webinar a grand success. Once again, I welcome everyone and wish you a great day ahead.
Thank you, Madam. Welcome you to this session. We have with us the backbone of Nitte Institute of Nursing Sciences and who has a capacity to translate the vision into reality. I invite our dynamic leader, Dr. Fatima De Silva, Principal College of Nursing, to give the opening remarks.
Very good afternoon to all the members and the participants who have joined this international webinar on recent advances in midwifery practice. Can you hear me, Timmy?
Yes, we can hear you, madam.
Okay. It's lovely to have an international speaker, that is Dr. Sunita Panda, in this forum. I'm sure all of us are going to be enriched with her talk on the trends and the advancements which are in the midwifery practices. Well, my dear colleagues, we know that as per the report of the Ministry of Health and Family Welfare, Government of India, in 2015, India became one of the 193 countries to commit to the Sustainable Development Goals, which include improving the maternal and infant health services. Keeping this in mind, Indian Nursing Council, along with the support of the government, has also taken great strides in creating a strong midwifery cadre by introducing the Nurse Midwifery Practitioner Program. There is a global acceptance and recognition of the midwifery model of care and skilled delivery for ensuring effective maternal health outcomes. Not only that, the midwifery practice will also strengthen our healthcare workforce, towards which our country's dream of an empowered workforce will be achieved, especially in areas where the resources are scarce. Though the maternal mortality has declined considerably in India, still there are nearly 350,000 pregnant women who lose their lives. It is the right of every mother to survive pregnancy and childbirth and have a safe delivery. I'm sure the midwifery-led care units will surely play a pivotal role in positive health outcome for mothers and children through timely management of the preventable causes such as hemorrhage, puerperal sepsis, complications of abortions, obstructed labor, hypertensive disorders associated with pregnancy. I also wish to inform that it was a novel initiative of the department under the proactive leadership of Ms. Shiny Paul and other colleagues who have established a nurse-led care unit, that is a childbirth education unit in our own parent hospital. And that was really a great role which was played by the department. And this unit is now independently providing lactation education and education with regard to antenatal care, as well as postnatal exercises are being taught to the mothers, as well as we have seen that we do receive referrals from the pediatric as well as the obstetricians in taking care of these mothers and counseling these mothers with breastfeeding issues. I think such proactive roles and has to be played by all nurses in midwifery will surely bring about a great change in the midwifery practice. I wish this particular session great success, and I wish Dr. Sunita Panda the very best, and we would be really eager to listen to you about all the recent advancements in the midwifery practice. Thank you.
Thank you, madam, for the words of motivation and inspiration. It's time for the most awaited session. Over to you, Dr. Sunita Panda.
I'm just opening my slides, okay?
Okay, madam.
Can you see my slides?
Yes, we can see your slides.
Perfect. Thanks very much. Well, first of all, I would like to convey my gratitude for inviting me to do this talk. I'm really delighted with the offer, and I hope I've included what Principal Madam just said, that this is time to talk about the advances in midwifery practice. And I really have tried to make this presentation very comprehensive in terms of a global perspective and a bit of examples from Irish perspective, and also keeping it in the context of all the countries across the world. Of course, if you have any questions, please work away in the chat box, or you can stop me and ask during the presentation as well. I have tried to integrate this presentation with some of the examples from my own research, which either directly or indirectly contributes to the current midwifery practice. And I would and also I share a few materials with you as additional reading materials for the participants to benefit from reading. Now, you don't have to read them all now, or having to read them before the presentation, but I hope you will get a chance to read them. They're all relevant to the current advances in midwifery practice. So the goal of midwifery, or the goal of a midwife, is to protect and enhance the health of women and babies. And we all know that how crucial it is, particularly with the changing, with all the transition and the current changes. It is becoming more and more important. And I was delighted to hear that in Nitte you have, I don't know if I'm telling it right, that you have a midwife-led unit where you educate women, and it's fantastic. This is one step forward to achieve this particular goal. As a midwife, this is our sole focus, to protect women and to protect and enhance the health of women and babies. Going back, looking into the history in brief, in 1954, an expert panel on nursing and on maternal and child health, they met in Hawk and recognized the importance of midwifery, and that's when it started. Up until then, nursing was the only known profession, only known discipline. But then midwifery was added into it, specifically for women and children. I'm going to talk about the advancements, not just for midwifery practice, but I'm going to start with midwifery education, midwifery research, and midwifery practice. To be honest, they cannot be separated. They're so integrated. And talking about midwifery practice alone is meaningless if you haven't talked about midwifery education, because that's when a midwife is trained and she progresses towards being a competent and confident midwife. So we have to talk about the advancements we have in midwifery education. We also have to talk about midwifery research. It's the key, because a midwifery practice, a midwife would be confident and competent if there is evidence-based practice. If the practice has been proven, has been recommended, has been proved to be the best practice, then that makes the midwifery practice very strong. And for that, we have to talk about the advancements we have in midwifery research. So first, coming to talking about current advancements in midwifery education. Now, these are some of the key points. There is more to it. There is emphasis on continuing professional development. And as we just heard Principal Madam telling that there are different other advanced courses, and we have to encourage our midwives, not just the basic training of bachelor's degree or master's degree. It's not an academic qualification. It's making yourself empowered and making yourself an expert, a real expert in the field of your practice, whether it's related to education integrated with practice and research, or whether it is practice alone. So there needs to be a strong emphasis on continuing professional development, and we actually research worldwide across all the countries of the world, and we have to learn from each other as well, from different other countries. There is a strong emphasis on continuing professional development. There are advanced midwifery practitioners, there are advanced neonatal practitioners, And there are lots of leadership and management skill courses that actually makes a midwife empowered in her current role. There is recognition for higher education. Earlier, when we talk about going back to when nursing and midwifery started, we were just talking about a basic nursing or a midwifery course and we were done with it. Nobody was even thinking of going for higher studies. Gradually, there was introduction of the direct basic BSc nursing, the 4 years degree nursing course, and then slowly there was introduction from diploma, there was introduction of the bachelor's degree. Then now more and more, you barely see any nurses and midwives stopping their basic education at bachelor's degree. They all go for higher education to master's level, MPhil, PhD level, and they also do small additional courses to make themselves an expert in the field of their practice. There are skill-based trainings and assessments, and that's ongoing. That's not just for students, as well as that's in the hospitals. And again, giving an example of here in the Irish hospitals, there is a training called obstetric emergency training. It's a multidisciplinary team, and I will be talking about the importance of multidisciplinary team in the later slides. There is a multidisciplinary team that includes physiotherapists, anesthetists, obstetricians, midwives, nurses, neonatologists, pediatricians, psychologists, mental health nurses and midwives. Everybody, they come together and they practice the obstetric emergency drills as well as routine care. For example, if we talk about one of the most common problems in obstetrics is preeclampsia. And preeclampsia or eclampsia, when it proceeds to eclampsia, it cannot be managed alone by a midwife or by one obstetrician. It needs a team effort. It needs anesthetists, it needs physiotherapists, it needs midwives, it needs managers, it needs obstetricians, so many people. And those skill-based training and assessments, and probably you have this, I actually don't have to acknowledge, I actually don't know if that's in practice in the hospitals in India, but that's something that's very important for everybody coming together and creating a scenario and rehearsing and going through the drill. So that's skill-based training. That's important not just for student midwives, but also for midwives who are in practice or obstetricians who are in practice. Then also there is emphasis on clinical learning environment. I cannot overemphasize the value of clinical learning environment, because that's the place where our student midwives get the confidence and competence to work independently as a midwife who will eventually help women and babies. And that level of confidence comes from the clinical learning environment. Later, when we move on to research, I might be able to actually give you an example of a systematic review that I have done with few of my colleagues from India, which has been submitted for publication. And that systematic review solely focused on exploring challenges faced by student nurses and midwives in clinical learning environment. It is so important, and some of the key findings that show that how students experience and their confidence and competence is influenced either positively or negatively, all from the clinical learning environment, the staff who they work with in the clinical learning environment, their own tutors, their instructors, their mentors, their preceptors, even from patients, even from their peers, that's their friends, their colleagues in the clinical learning environment. And there are, of course, there are organizational factors, the resources available to them, but it is so important to make sure that the clinical learning environment is soothing, is conducive, is the most comfortable environment and the appropriate environment for student midwives to build up their confidence and competence. Going years back, even before I entered into nursing, I had no idea what it was going to be like. And when I went, it was a clinical learning environment that actually created a lot of fear in my mind at the start that, oh my God, this is so challenging. I don't think I can really cope here. And if our students enter into nursing or midwifery with that fear and come out with the remnants of that fear, how can we expect them to be confident and competent midwives in clinical practice? And what sort of training they would give to their future generations, to the midwives or students who come to the clinical learning environment, they would probably pass on. If they had a negative experience, that will be passed on to the other students and midwives, student nurses and midwives, and that probably keeps happening. So it's so important to ensure that our students, when they come out of clinical learning environment, they come out with full confidence, competence, and feeling empowered. And that positivity will be transmitted to the next generations. Coming into talking about current advancements in midwifery research, we have done a lot of advancements in research, I must say. Years ago, we never talked about, like, I can say when I was doing my own bachelor's degree, or even parts of master's degree, there was very little focus on research. Apart from my own research, I wouldn't have really gone through reviewing a lot of literature like the amount that we do now at this current age and stage. But it's a very good advancement that there is a lot of focus on research, and most important of all, that's how it integrates to midwifery practice. We try to make sure that whatever we practice, that has a background evidence to guide us in that practice. And I will give you lots of examples when I come to how evidence-based practice guides our own practice. Let's look into some of the examples of advancements in midwifery research. There is women-centered care and women's involvement in decision-making. We had never heard about it years ago. We had never heard giving importance to women's decisions or involving a woman in the decision making. Rather, if a woman, and I can say that for sure this is still happening, that woman has no role in the decision for her own care or her mode of birth or any of that. But now, the first thing that comes now, there is informed consent, and there was always consent before a surgical procedure. But now there is informed consent. And when we talk about informed consent, the woman needs to be well informed before she signs a consent or before she verbally consents to undergo a procedure or an intervention. We talk about the woman as the topmost priority, and Principal Madam kind of highlighted that as well in the talk, that it's the woman that we are focusing, and it starts all with the woman. Is she happy? Are her needs met? Are they appropriate for her? And there would be women who would not understand and who, might make decisions that are not appropriate for them. They might make decisions based on just anecdotal evidence or their own beliefs and fears. But that's where our role comes in, and we are the guides there. We are the advocates for them. Okay. Coming to the next thing, importance of research and advancements in research. There is emphasis on local, national, and global concerns. And I have an example here for rising rates of cesarean section, and that's directly linked to my doctoral study research, where I looked into factors that influenced decision-making for cesarean sections for first-time mothers. We all know the growing cesarean section rates are becoming a growing global concern, and we are trying to find out ways to reduce unnecessary cesarean sections, or I must say inappropriate cesarean sections, or we are also trying to find ways to stop the rising cesarean section rates. But to do that, we have to take one step back and think, what is influencing the rising rates? Every year, there is a steady rise in every country across the world. There's a steady rise of cesarean section rates. So my study focused in exploring the factors that influence decision-making from the provider's perspectives. So I involved, and I will talk about it when we come to, involving key stakeholders in research. I involved midwives and obstetricians, all obstetricians at senior level and midwives who were working in the labor ward, who were directly involved in the decision-making process for cesarean sections in 3 hospitals in Ireland. And that has guided, so it is the providers or the decision makers' perspective. And they say, here, these are the reasons, these are the things that influence our decision making. And that has a direct link to guiding local, national, and global policies. Now, of course, I have compiled them together and developed a video where I have brought together all the findings, and this is an example how your research can have a link to policy making. Now, I'm going to bring these findings and present them with doing seminars to clinicians in all the hospitals, where I'm going to ask them, based on the basis of these findings, let's come up with action, with strategies to take action to do something about the inappropriate rising cesarean section rates. So do you see how your research can have link? Now, again, going back to years ago, we never talked about research, or we never talked about influencing the policies through our own research. But here at this age and stage, we can actually even talk about it, that yes, our research findings can have an impact in developing or redeveloping or revising the policies. Other research most important advance is focus on practice perspective. Okay, we would have done a lot of research when research came into focus, and when we started talking about evidence-based practice, we talked about doing research for overall developments, large-scale research and all. But now we are talking about small-scale, really small research. Of course, we are still doing the large-scale research, like broader topics, okay? But we are also doing small, with a narrow focus. For example, and when I come to the evidence-based practice, I'll give you an example, and I have a few examples there. For example, when I started in Ireland, the hospital where I was practicing, we did not let women eat or drink during labor. And I'm talking about it at least 10, 12 years ago. Women were not allowed to eat or drink during labor. Okay, slowly we reviewed a lot of research findings. A lot of research findings came in that actually showed there is no harm in letting a woman eat or drink during labor. Not heavy eating, heavy drinking, but to maintain, to keep herself refreshed, energetic, and not to let her starve during her labor. Labor is already an exhausting process. So women were, up until then, women were only allowed, I still remember we used to take a cup of ice, and we used to put a stick or a tissue or something to hold the ice. The ice cube had a hole in it, and we used to let the woman to give ice lollipops, just soft to wet your lips so that you don't feel the dryness in your mouth. I can't believe we actually did that. But for years now, we have been letting women eat and drink during labor. Of course, we don't allow women to eat or drink if there is any risk of the woman undergoing a surgery, any potential reasons. Of course, you took extra additional care. You kind of avoided any eating and drinking. Rather, you gave her sips of water, or just you kept her hydrated or kept her refreshed, and giving her some cold water and just a warm cup of tea or something like that. But of course, the practice, that's a small thing, but it's a huge thing for that period of time for the woman who is going through the process of labor. So do you see how the focus of, and if that research was not done at all, we would not have changed that particular practice. And I have lots of examples later. When we come to that slide, we'll talk about those examples. Another advancement in midwifery research is integrated research on enhancing normality for women and babies. We are focusing on enhancing, improving normality for women and babies, whether it is through improving antenatal education or assessing a woman's knowledge, attitude, and then eventually changing our practice, or doing lots of small trials or interventions to see what's more effective, or let's say teaching yoga to women antenatally, or teaching hypnobirthing, or teaching relaxation techniques for labor to cope with labor pains so that they can avoid pharmacological pain relief in labor. So everything is focused towards enhancing normality for women and babies. And it's needless to say how many research activities are ongoing, solely focusing to promote normality for women and babies. And the other advance is that there is emphasis on research related to midwifery education. And I just gave you one example of my own systematic review with my team of colleagues from India on challenges experienced by exploring challenges experienced by student midwives and nurses in clinical learning environment. And the aim of that is really to find out what factors how students actually, we have an anecdotal evidence in the back of our mind. Student nurses and midwives are terrified of clinical learning environment. When they have clinical postings, in general, not everybody, but in general, most students are terrified of going into clinical practice. And we have tried, through our systematic review, we have tried to find out the why behind that fear, that unknown fear. And if we can figure out the reasons, the factors that triggers that fear, then we can address some of those factors or all of those factors to see if we can overcome those challenges to make clinical learning environment a very comfortable, conducive, and appropriate environment for student nurses and midwives to learn and to feel competent and confident and feel empowered. So that is one example of emphasizing midwifery education. There are a lot of other research activities ongoing. For example, you all must have heard about OSCE. So OSCE is something like really creating a live-like situation and letting students practice there for examination or for their clinical skills and all. And like, for example, newborn resuscitation. A midwife needs to be an expert in conducting newborn resuscitation in case you have an unpredictable baby who requires resuscitation. You need to be empowered with the skill to handle that situation, to help the baby survive until further helps arrive to you. So, it's something like those small research. So there is a lot of research going on related to how the clinical skills can be improved. What sort of skills can be improved? Taking perspectives from students, taking perspectives from clinical staff, perspectives from clinical instructors, policymakers, educational institutions and universities, and hospital policymakers. It's so important to understand all those perspectives to do the best for our student nurses and midwives, because at the end, we want competent student midwives who can competently provide care to women and their babies. Now let's come into discussing current advancements in midwifery practice. So I'm just checking the time to be sure we're not running over time. Current advancements in midwifery practice, I'm going to talk about that in these points. First of all, there is an interdisciplinary team approach to maternity services. I'm comparing to how it was years ago to highlight on the advancements that we experience now. Years ago, there was no discussion of involving midwives or nurses in the decision making for the maternity service, overall maternity service. Now you see nurses and midwives having a say when there is a discussion about developing or redeveloping maternity services or revising hospital policies. And any institution that does not have that, they should have that, because it has been proven to be of advantage. When I talk about interdisciplinary team approach, let's go into those slides. I have slides for each of these to discuss with different examples. So going through this list of current advancements in midwifery practice, we will be talking about interdisciplinary team approach, development of community-based midwifery services for low-risk women, midwife-led care, and it's endless, needless to say the importance of midwife-led care, evidence-based practice, and leadership in midwifery, and involvement in policy making. We'll discuss each of those in detail now. This is an example. This is the conceptual framework I have got from one of the studies, and I think I have shared that study with you all. It's just interesting to see how interdisciplinary team approach can be effective in making the maternity services strong, or any service, particularly maternity service, because you cannot, as a sole healthcare professional, you cannot do the best for women and their babies. You need the whole team approach. Of course, midwife has to be the strongest factor in the team. Now here this conceptual framework actually shows different factors that determine how your interdisciplinary team approach would be in an organization. I'm not going to go through in detail about all those, because there are varieties of factors, resource, philosophy of the institution, administration, the culture of the institution, infrastructure, hierarchy, managers, midwives, everything. There are conflicts, interactional factors, and different factors. So everything is valuable when you talk about an integrated approach, an interdisciplinary team approach. Here, when we talk about it in detail, about the different factors, conflict can be over professional philosophy, over autonomy, over work style, over compensation issues. The different organizational factors that can actually, affect your interdisciplinary team approach or integrated practice would be philosophy and mission. Okay, you have your individual philosophy and beliefs, and there is a philosophy of the institution, and every individual's philosophy principles, they vary from each other. Administration issues, resources is quite important, culture, the infrastructure, power and status. So going back, as I told you a few slides back, it's an interdisciplinary team approach. For example, if you have let's say one of the examples of, I gave you the example of preeclampsia. Similarly, let's say an example of postpartum hemorrhage. How would you manage that? You alone as a midwife and having an obstetrician beside you is not enough. You need anesthesiologist there. You need the blood transfusion medicine center person to calculate what products can be available to the woman, what products she can get. Like it's like using the expert services from all the experts to do the best for the woman. And this is shown by evidence. You use the expert services and you want the best outcome for the woman. So I cannot overemphasize the importance of interdisciplinary team approach. And that's one of the advancements that we have noticed. We do involve different multidisciplinary professionals to handle situations. Community-based midwifery service. Okay, this is very important, and again quite important for women who fall into the low risk category. And most women who conceive, go through labor and birth, and their postnatal period, most of them fall into the low risk category. Not all of them need to be seen by an obstetrician from day one up until they have their baby or afterwards. I want to give you and show you an example of how the maternity service in Ireland works, and there is community midwifery service within that, integrated that. Now, it might look a bit complicated because in a way it is, in a sense that there is shared care. So women can book for shared care during their pregnancy. They can book with a GP, their general practitioner. Otherwise, they're called as the GPs or family practitioners, family doctors. And then they also book with a hospital. So they go for one visit to the GP, one visit to the hospital. And almost all women, they do that. And first of all, maternity service is completely free to all women who are residents in the Republic of Ireland. Second type of care, there is a domino scheme. That's domiciliary midwife in and out. That means it's a midwife-led service where all low-risk women are cared for by experienced community midwives during pregnancy, labor, and postpartum. And one of the most interesting, very beautiful part of this is that the same midwife who meets the woman antenatally, there is every attempt is made to make sure that same midwife is available when the woman presents in labor or during birth. And that same midwife is available to the woman to see her postnatally and follow her up postnatally when she is discharged from the hospital. That's the beautiful part of domino scheme. Now, that's not possible all the time, but anytime that's possible, that's facilitated. Community midwives, there are self-employed community midwives, very small numbers, but they provide care in specific area to low-risk women, even they facilitate home births, which is the next point. And there is one self-employed community midwife to provide care to the woman antenatally throughout antenatal period and throughout postnatal period. But when it comes to labor and birth, a second self-employed community midwife would be facilitated to join the first one. So there will be two midwives during labor and birth, and they facilitate home birth. But of course, anytime any complication arises, any deviation from normal that cannot be managed safely in home environment, the woman would be transferred to the hospital. There are midwife-led clinics, and it's needless to say, as you said, as the principal madam said, like you have started this nurse midwife-led care or clinics. And these clinics, they actually see women, they do their antenatal checkups and everything. They're totally responsible for this woman. Of course, there are obstetricians, there is obstetric model of care available if a woman needs to see an obstetrician for any deviation from normal. This is an example of how it works in Ireland, but I wanted to share this with you to tell you how community midwifery service is integrated within the existing maternity service in Ireland. Midwife-led care, there are midwife-led units, and they're one of the examples of how the midwifery model of care is being integrated into the existing health systems to transform maternal health around the world. And this has been gaining a lot of attention over the last number of years. Midwife-led units, and there are a lot of studies that have compared the outcomes from women who were looked after in midwife-led units to women who were looked after in obstetric-led units. And one of the key outcomes was that women felt very satisfied. They were really happy. They had an extremely positive experience when they were looked after in midwife-led units compared to women who were looked after in obstetric-led units. One of the other outcomes was that there was no difference in the rate of cesarean section as such. But any woman, as I told you, the overall experience, of course, there was less use of pharmacological pain relief in labor for women who were in midwife-led units, less perinatal tear, less episiotomies, less interventions. And those were contributing to overall women's positive experience. And there was no harm in being looked after in midwife-led units. So there is all evidence suggesting keep your low-risk women out of obstetric-led care and keep them all in midwife-led units, under the care of midwives. But going back to what I told you earlier, for that, we need to produce confident and competent midwives who can actually make the right decision at the right time for every individual woman they care for. The other midwife-led care aspect is to promote normal physiological pregnancy and labor, and supports the natural ability of women to experience birth with minimum or no routine intervention. And that was the sole focus of midwife-led units, to keep the interventions absolutely away until and unless it's absolutely necessary. Okay, and benefits, and this is strong research evidence that there is increased rates of maternal satisfaction and a decrease in unnecessary medical intervention for women who were in midwife-led care. This is a study from Professor Jane Sandel from King's College London, and she's big time into place of birth, midwife-led care, and these are quite interesting, and they are quite motivating to tell you what midwives can do and how beautiful it is to keep women away from obstetric-led care, away from all sorts of intervention, because a woman's body is meant to go through the physiological pregnancy, labor, birth, and postpartum transition. Yet, we introduce interventions at every stage, deviating the woman and not letting her body, not giving her body a chance to do what her physiological body can actually do. So these studies are very thought-provoking, and hopefully in long run, it will bring in practice changes in every country. Evidence-based practice. We did talk about it very briefly, and here are some more on it. Okay, why do we need evidence-based strategies in practice? To improve maternity care, to improve outcome for mothers and babies, and to translate research evidence into practice where we can competently and confidently stand up and say, well, I'm not doing this because this is not evidence-based. Okay. For example, there are lots of discussions going on here, and we are big time into whether to do a CTG, continuous CTG for a woman, cardiotocography monitoring in labor, or not to do continuous CTG and just to do intermittent auscultation of fetal heart rate in labor for women who are low risk. Years ago, when I started in Ireland back in 2005, as soon as a woman appeared, the first thing we did, as we were saying, hello, how are you? And we were taking history, we were strapping her to the CTG monitor. That practice is well gone now. And that practice is still in for women who come for private care and the private consultant wants to see a CTG. Until and unless the woman actually requires that there is a specific indication, you do not need to do that. And I can stand up as a midwife and I could say that now, here, doctor, this is not evidence-based. This woman is totally low risk and she does not need a CTG done in labor. And I can say that only if I feel confident that, yes, I'm sure there is research evidence. So evidence-based practice is so valuable. And that was a small example. There are more and more examples to guide every single aspect of our practice. Other evidence-based practice topic would be research involving key stakeholders. And as I gave you example from my own doctoral study, where I interviewed obstetricians, midwives, and some of those obstetricians were policymakers. They were developing and revising the policies on annual basis, on a yearly basis in the hospitals. Also, I interviewed midwives, senior midwives, managers, midwives with all ranges of qualification, newly qualified midwives. Also, I interviewed women who had a cesarean section for their first birth. These are our key stakeholders. Involve them. Bring their point of view together. Okay? And one of them, when you actually do research like this, nobody can actually stand against you and say that, but so what? You can say, so what? Because we have women who you are caring for. We have care providers who are providing the care. And they all say that this practice needs to change. And you can strongly stand up and say if you have that evidence. For example, from my own study, one of the evidence that I found that women said, so I asked women, first of all, I asked what influenced the decision to birth in their case. Why did they have to have a cesarean section? Because all my interviews, they have cesarean section. And I asked the clinicians what influences their decision making for cesarean section. Also, of course, I asked women, did they feel involved in the decision making process? Now, women said that we only go with the flow of the professionals' decisions, professionals' recommendations, whereas clinicians said, oh, all our decisions are discussed, shared with women, and women agree to it, and hence we proceed with it. So do you see there is a parallel system of care where clinicians say something else and women say something different? Okay, and that needs to be addressed to get to the key point. There are also other examples of high quality research, systematic reviews, meta-analysis or meta-synthesis, randomized control trials, large cohort studies, etc. Sorry, just taking the time again. They're still okay. So I'm going to give you some examples of, now these days, you must have heard me already saying that I talked about systematic reviews. They are robust. They are strong. They sometimes work like dynamite. When you talk about one primary single research, and when you talk about multiple research on the same aspect, bringing together one new evidence, it becomes really powerful. When you talk about systematic reviews, either meta-analysis or meta-synthesis, of course, it's important, randomized controlled trials, you need to try out an intervention before you could say that, yes, that intervention can be applied, can be generalized, and can be taken into consideration to improve the practice. Also, there are findings from large cohort studies. I'm going to give you a few examples of evidence-based practice and how it influences clinical practice. I told you earlier about eating and drinking in labor. Delayed cord clamping, that's another example. I think I have sent you all these studies in the additional materials. Midwife-led care, how midwife-led care, it was introduced years ago and it slowly came into practice. And then a comparison was made to see if midwife-led care, if there was any difference between the outcomes and satisfaction for women who were in midwife-led care to women who were in obstetric-led care. And that finding guided future practice for more countries to think of developing midwife-led units, midwife-led care, or separating low-risk women from obstetric-led care and keeping in midwife-led care. And of course, you need obstetric-led care as a backup if anything deviates, because pregnancy, labor, childbirth is so unpredictable. If anything deviates from normal, the woman can be transferred to the obstetric-led care. But that's how that has guided our practice. And many countries have come up with midwife-led care and midwife-led units. Also, some of the other examples of evidence-based practice strategies would be effect of maternal birth positions and duration of second stage of labor. Now, these are all small research topics. These are randomized control trials. But there are these primary research studies have come together into a systematic review and meta-analysis to show that, let's say, for example, there are 10 studies that have tried different birth positions to see which one is most effective and which one has an effect on duration of second stage of labor. And here is a systematic review and meta-analysis that produces the findings that these are the birth positions. If adopted during second stage of labor, it reduces the duration of second stage of labor. These are the birth positions, if applied during first stage, they reduce the duration of second stage of labor. Now, this is again another example of how it can actually guide your practice. And then eventually it gets into your routine practice. Giving you an example of research involving key stakeholders, I did a study, this was done in 2015, now published in 2018, where I actually went to Sweden. Sweden is a country, one of the European countries. There are a lot of European countries, about, a lot of them have a very low rate of cesarean section, very low rates of intervention. And Ireland doesn't. Ireland has a, compared to those European countries, those they are Scandinavian countries, Ireland has a very high cesarean section rate and high intervention rate. It's above 30% at the moment. So I went to Sweden, that's 2015, when the cesarean section rate was around 16-17% in Sweden. So I went to do interviews just to really, out of my curiosity with the small funding, I really wanted to know what influences their decision making in those hospitals and how they have successfully maintained such a low rate of intervention and low rate of cesarean section. So I went to 2 hospitals in Sweden, and each of those hospitals had a cesarean section rate of 12 to 14% during my data collection. And I did 4 focus group interviews, 2 with midwives, 2 with obstetricians. And this study was very close to my heart because that was my first ever, doing interviews with people, and after my master's, of course, and, really listening to people and writing a paper and bringing it out for publication. This is what they said. These were my key themes that came out from that study. Now, this study had a big impact in Ireland because we had a lot to learn from other countries and their practice, what influenced their decision making. I would have shared these findings with a lot of clinicians in many other countries, purely to really enlighten and focus that how important it is to believe that normal birth is the topmost priority. So both obstetricians and midwives from the 4 focus group interviews, they told one key thing, that our belief in normal birth, which is in our culture. We don't talk about cesarean section, we don't talk about interventions until and unless it's absolutely necessary. And that is the key that has helped us to maintain a low rate of cesarean section. Of course, there are other aspects, and I'm not going to go through all in detail. But what I want to highlight here is that involving key stakeholders and their views. If I had randomly gone and asked people in Sweden or any other people who were not actual decision makers of cesarean section, the study wouldn't have been so valuable. But now, because I spoke to the decision makers who were providing care, directly involved in making decisions for women, the study was very valuable, and the findings are still valuable, and we are still giving example of Sweden in our clinical practice. Another example of systematic review and metasynthesis, for example, I just showed you the Swedish study findings. That was a primary study. But my systematic review that was published in 2018, that brought together 34 studies, and I've updated the search, which is not in the published paper. So there are total about 41 studies there were until end of November 2018. But this published paper has findings from 20 countries involving 34 studies from over 9,000 clinicians. And the sole focus of this study was to find out what influences their decision making for cesarean section. And this is like, this is robust. It tells you. So when this systematic review findings were published, and I want to give you an example of how it can actually influence your practice. This went out to media, and I was interviewed by Irish media, radio interviews, live interviews, lots of magazines, 7 media interviews, live interviews, plus different other countries approached me to do interviews to find out what have I found. Because surprisingly, this systematic review wasn't done. So it was really valuable, really, to understand what clinicians perceived, what influenced their decision making for cesarean sections. We're just talking about the growing concerns with rising cesarean section rates, but have they actually tried to find out what influences their decision making? So here were the findings. And one of them, I'm not going to go through everything in detail, but one of the key findings was that it was clinicians' personal beliefs, their own attitude towards cesarean section. Most of them felt, well, cesarean, so why not cesarean section? It's a very safe procedure. It's very safe. It's gone very safe with safe anesthesia, safe surgical techniques and everything, and good recovery. So why not cesarean section? So this is actually just to tell us in one slide that here is what clinicians say that influenced their decision making. So what are the key outcomes of the current advancements in midwifery practice? We have come a long way. And the outcomes have been, quite evident as well. And yes, we still have a long, uphill battle. And there are lots of countries that still haven't achieved everything. And we still have a, long way to go. But there is evidence that there is improved quality of care for mothers and babies. There is decreased medical intervention to a great extent. The breastfeeding rates have increased, and there is increased maternal satisfaction. There is decreased antenatal hospitalization or postnatal rehospitalization after birth. There is increased independency for both women and the midwife practitioners. And there is increased job satisfaction among midwives, where you are actually held responsible solely for the woman and baby you are looking after, and you're doing everything and proceeding to the positive outcome and positive satisfaction among women. What factors contribute to the current advancements? It's our motivation, how motivated I am to make myself an expert, to feel confident and competent in my current role. It's also taking examples from other countries, and as I gave you we are taking examples from Swedish practice. It's initiatives of individual midwifery researchers to progress research and to make practice evidence-based. It's research evidence of better outcomes in midwife-led care that kind of motivates us that, yes, why not start a midwife-led unit or midwife-led care, something small, and then proceed. Transition of midwifery programs into higher education. Preparedness and awareness among women, very important. Here are some of the challenges for future. Creating an identity for midwives across the world. Building up the confidence and motivation among our midwives. Very important is bridging the theory-practice gap in midwifery education. I cannot overemphasize it. It came up frequently from the systematic review on challenges faced by student midwives in clinical learning and student midwives and nurses in clinical learning environment, that there is a big gap between theory. We learn all research says this, but when you come to practice, that's all gone. Practice is totally different. It's totally based on the traditional way of practice. Some nurses and midwives, they have their own way of practicing things, and they stick on to that. There is a big gap between research evidence or theory learning and clinical learning. And we need to do something to bridge that gap, to reduce that gap, to minimize it, so that students feel, yes, this is what I learned in the classroom, and this is what I'm practicing in the clinical area. So that means this is the robust practice. They need to feel that there's no confusion among student midwives and nurses. Also, strengthening the role of midwives as independent professionals from a practice perspective, making midwives lead the unit, manage, taking charge of it. These are all challenging. Building up of strong academic workforce worldwide, strengthening research to contribute towards global perspective, placing emphasis on women-centered care. I cannot overemphasize the value of research and bringing research into your practice, because that gives you a backup confidence that makes you empowered to say that, well, this is what evidence says. These are all challenges. I'm not saying it's all very easy to achieve them, but we can slowly and surely achieve them if we try towards it. And we all have to share the common vision that we have to prove ourselves empower ourselves as, independent practitioners and competent and confident midwives, so that we can move into a changing world eventually. And these are some of the selected references. Thank you. If you have any questions, I'm very happy to answer.
Dear delegates, if you have any queries or questions with regards to the above matter, kindly put up in the chat box.
Dr. Sunita, it was wonderful to listen to your elaborate presentation on the recent advancements in midwifery. And we are really happy to know that midwives are doing a really great job in their practice areas. And I know you are a great researcher because you have even published some few papers, and you are also involved into policy making decision. You were able to make some changes in the policies. So really, we salute you for your great work and wish you all the best to continue the good work in the field of midwifery. I just wish to know like whether there are any possibilities of having collaborations, because I'm sure you were in India and you know the training programs which have been happening in the nursing colleges. You said that there's a lot of gap between the education and the practice. Now, what do you recommend to bridge that gap between education and practice? Because you know what you know about the practices which have been carried out in India. So I wish to know, like, how do you bridge that gap?
Ma'am, first of all, thank you very much. Yes, so this is directly linked to your question. Is directly linked to what we have found from the systematic review, recent systematic review, and I'm hoping it will be accepted for publication because we got some minor revisions and we have submitted the revisions. I just submitted it last week, and we are hoping it will be accepted for publication because it's the key. Once it comes out, it will kind of enlighten our thoughts about how we can reduce the gap, and reducing the gap between theory and practice was one of the aspects in that. So coming to your question, ma'am, one of the things that can be done is, one of the things that students found it challenging was the attitude of the clinical staffs and attitude of the clinical instructors who went for clinical supervision. So if we can actually, it's the clinical staffs who would need to be involved when it comes to supervising students. So a close collaboration between clinical staff, clinical instructors, or mentors and preceptors, and students, having one goal, that students learn this in theory, they learn this in practice. How can we bring it together? We have to do the collaboration with the clinical staff. When we keep clinical staff for the hospital side and clinical instructors for the university side, the students are in the center, totally confused. They stand totally lost, and that actually brings in the fear in their mind, and that does not make their learning effective. So it's bringing together everybody, and that's what was the thing that we found, that students felt those things quite challenging, that instructors were not present all the time to see how students experience their clinical learning, and that's a gap everywhere. It's a gap in all, every country across the world. So to reduce the gap, the best thing to do, as I said, would be your clinical staffs, your clinical instructors, and your students have one single aim for the student, with the collaboration and ongoing coordination and collaboration with clinical staff. And because we have to understand the clinical staff situation as well, sometimes the hospitals could be so busy that they barely think about the presence of the student. The student is lost there. So how clinical instructors or university staffs can actually help students to manage that situation. That's one of the key things to reduce the theory practice gap.
Yeah, my another question was, you said that there's an 18 months training program for nursing midwifery in Ireland. Is there any possibilities of having a collaboration with the Nitte University, wherein our students who pass out their bachelor's program will be able to have some bridge program, so that they are good midwives or they are trained midwives, especially I'm talking in terms of skills. So is there a possibility of having collaboration with the place of work where you have been working, or the university to which you have been affiliated to?
I haven't heard of any such collaboration. I know there is one collaboration between European countries, and it's not as such collaboration. It's like students have something they call is elective placement. Now that hasn't happened since the last year because of the pandemic, but students are allowed to pick in any European country, so it's all within Europe, not outside Europe, where they are allowed to pick an European hospital where they can go and do their 2 weeks or 3 weeks of elective placement solely in the labor ward and solely in the antenatal care side of it and postnatal care, just those focusing on those 3 aspects only. And they do that under the, so the hospital heads would need to agree. University sends letters and a student does all these processings and the hospital agrees, and that's solely focused on elective placement. But I haven't heard in terms of education if there is any such collaboration, and the best source of information for that would be, ma'am, if you actually contact the university directly or the head of the School of Nursing and Midwifery to find out. Like there are, there is Trinity, but there are also other universities such as University College Dublin. There are other countryside universities as well, large universities. That would be the best way to approach that, man, to contact the head of School of Nursing and Midwifery in those universities to find if there is any possibility of such collaboration. To my knowledge, I haven't heard actually.
Yeah, thank you. And the community midwives who work in your area, are they registered nurses?
Registered nurses and registered midwives.
I'm talking about the community midwives.
Yes, everybody is registered nurse and midwife. So you cannot be a midwife or a nurse without undergoing your nursing course or midwifery course or the combined nursing and midwifery course. So everybody is registered nurse and midwife.
In India, we have something called as auxiliary nurse and midwives. So they are the ones who are in the community and the ASHA workers who render these midwifery services to the people in the community. Because the midwives, registered nurses and midwives are mainly focused on the hospital sites, but not in the community areas. So that's how it differs in India. Whereas I think midwifery practice is very, very strong and strong in Ireland. That is what I understand.
Yes, the community midwifery practitioners, ma'am, they all undergo the same amount of training, rather additional training to handle. They do community midwifery service under supervision of senior community midwifery practitioners before they are independently left out to look after women in community. So they rather go through more robust and additional training. So yes, they're all registered practitioners. Plus they undergo additional training for to work as independent community midwifery practitioners.
We would also love to have some collaborative work with you, Dr. Sunita. Maybe explore in this area further and see if we could work together in some research aspect of midwifery practice. We are looking forward for that. And thank you so much once again.
Thank you, ma'am. You're very welcome. My pleasure. I'm happy to take any more questions if anybody has any.
I understand there are no queries in the chat box.
Okay.
The sessions are well understood. Thank you, Dr. Sunita Panda, for the updated presentation, which included with evidence-based practice and systematic review in recent advancement in midwifery practice in Irish settings. Thank you, madam.
Thank you. My pleasure.
Yes. It's my privilege to invite Professor Philomena Fernandez.
Good evening, everyone. A perfect combination of love and gratitude is essential to vitalize our life in an admirable manner. Good deeds of excellent people deserve a handful of thanks enriched with love. So, I'm here to thank you all for contributing to the success of this webinar. First of all, I deem it a pleasure to thank God Almighty for the successful execution of this webinar. Cooperation, dedication, and motivation is a fortunate secret of Nitte Usha Institute of Nursing Sciences, which is headed by our beloved principal, Dr. Professor Fatima De Silva. Her excellent style of administration and management inspires us to accomplish our objectives in a more fruitful way. We are grateful to you, ma'am. On behalf of the organizing committee, I extend my sincere thanks to our resource person, Dr. Sunita Panda, who has been kind enough to accept our invitation and for giving an excellent coverage on recent advancements in midwifery practice. Thank you so much, ma'am. I also wish to express my gratitude to all the participants because of whom we made this webinar possible. I humbly submitting my heartiest thanks to Ms. Samshina, organizer of this webinar. And also, I would like to thank all my colleagues for the unwavering support for the success of this webinar. Lastly, I would like to end with this quote given by Mother Teresa. We ourselves feel that what we are doing is just a drop in the ocean, but the ocean would be less because of that missing drop. I thank each and everyone for finding the tiny drops to make the mighty ocean. Thank you, one and all.
Thank you, Madam Philomena. Well, let's wrap up our session. On behalf of Department of Obstetrics and Gynecological Nursing, I thank all for making the time in your busy schedule to join us here this afternoon. Wish you all a pleasant evening. Once again, thank you one and all.